Hello, I am Dr. Alok Gadkari, consultant spinal surgeon at Symbiosis University Hospital and Research Center, Pune.
Hi, I'm Dr. Bharti Devkar Sharma. I'm a professor in orthopedics at Symbiosis Medical College for Women, Pune.
We are here to present a very rare case which we have recently operated here at Symbiosis University Hospital. She was a 14-year-old girl who presented to us all the way from Buldhana. On presentation, she was completely bedridden since 1.5 months and unable to move any of her 4 limbs with associated urinary incontinence. The patient on primary presentation had a 1-month-old MRI scan which showed C1-C2, which is upper cervical spine complete collapse, which was suspected of TB spine. After admission, we got repeat imaging which included MRI and CT scan done. Based on the imaging and discussion with the radiologist, we decided to take a multidisciplinary approach which involved including the skull-based surgery team, the spinal surgery team, as well as discussing with the anesthetist and the intensivist in our hospital. After appropriate counseling of the relatives, we decided to proceed with surgery, which involved a posterior, which is back of the neck, and anterior, which is front endoscopic approach for this patient. The surgery went off very well. The patient was extubated as soon as the procedure was completed and was shifted to the ICU. One day post the surgery, the patient was shifted back to the ward.
Now the patient on day 5, the patient was given an appropriate collar for her neck and she was made to sit. On day 7, she was made to stand, and we are hoping that she improves steadily and is able to do all the activities nicely by next week or so.
My name is Dr. N. Ramakrishnan. I am the professor and head of department of ENT at the Symbiosis Medical College for Women at the Symbiosis University Hospital and Research Center.
I am Dr. Gaurav Chamania. I am an assistant professor at Symbiosis Medical College for Women and Suhrc.
This girl, 14-year-old, she was referred to us with complete total weakness of all the 4 limbs with no movement at all. The aim of referring was to decompress the anterior part of the spine, which had a lot of infection and disease and pus, and this had to be now anterior part approach is a difficult approach, so therefore we decided to take a very minimally invasive approach through an endoscope through the nasal corridor.
So this surgery involved use of endoscopes, high definition endoscopic cameras, along with high speed drills and microdebriders. What we essentially did was a scarlet surgery which involved approaching the spinal cord or the cervical vertebrae through the nose. So this gave a minimal morbidity to the patient in form of minimal blood loss, a faster recovery rate, and most importantly, there were no sutures on her face. There were no scars or sutures on her face or anywhere on the neck. The surgery involved going through the nose up till the back of the nose, which it involved removing the posterior wall of the nose along with the cervical vertebrae. There was a lot of infective material and pus which was compressing on our medulla oblongata and the spinal cord. Our surgery enabled us to take out all that material, thereby decompressing the load on the spinal cord and the medulla oblongata. We are glad to inform you that after post-op day 5, the patient was shifted to the general ward, and the patient was able to have power in all 4 of her limbs, and she is now able to stand, and hopefully she will be ambulatory as we go forward.
I'm happy that this has been done in a very efficient manner. This is a challenging case, and we have a great professional team here, very competent, and we have the experience of having done these kind of cases earlier, and we will be able to handle such cases in future also.
I am Dr. Nitin Balme, consultant anesthesiologist with Symbiosis University Hospital and Research Center. The challenges in these cases were to maintain the injury to the upper cervical spine, to maintain moderate hypothermia, and to replace blood and blood products with the blood products and to extubate as early as possible. To prevent neck injury, we did direct laryngoscopy and intubation with the collar there. And to prevent moderate hypothermia, we maintained temperature around 33 degrees Celsius with the use of warmers and by covering the patient. Blood, as the surgery was very lengthy and the blood and blood loss was expected, so it was calculated and replaced with the blood and blood products. And finally, as the patient was stable and the hemodynamics were constant throughout the surgery, so we decided to go for the early extubation and the patient cooperated well.